Hello, and welcome to St. Louis County Library's virtual program, Science in St. Louis, presented by the Academy of Science St. Louis. My name is Denise Chappell, and I'm the Adult Programming Specialist for St. Louis County Library. And before we get started, I have a few things to note. Today's program is in a webinar format and is being recorded to post to our YouTube channel in 3 to 4 business days from today. As a webinar, your cameras, microphones, and chat features are turned off. Towards the end of the program, I will enable the chat box to post your questions and comments related to this program. However, there may not be time to answer all questions. Lastly, today's program will have captions enabled. Should you wish to turn the captions off, find the CC Live Transcript button on your Zoom control panel, click it, then click on Hide Subtitles to turn it off. It may also be found under the More button, which is noted with the 3 dots on your Zoom control panel as well. If you are experiencing any technical difficulties throughout the program, please reply to the confirmation email and I will do my best to address your issue. And I also invite you to check out St. Louis County Library's new YouTube channel and our website, www.slcl.org, for information regarding curbside services coming into our branches, as well as information about other upcoming programs. So thank you so much for attending Science in St. Louis. Next, I'd like to introduce Natalie Bachman, who's a STEM Program Outreach Senior Associate at the Academy of Science St. Louis. And she's going to tell us a little bit about the Academy. So welcome, Natalie.
Thanks, Denise. Hello, everyone. My name is Natalie Bachman, and I am with the Academy of Science St. Louis. We are very pleased to be partners with the St. Louis County Library to bring you tonight's Science in St. Louis seminar, Famished. For those of you who are not familiar with the Academy, I'd like to take just a little moment to tell you a little bit about who we are. The Academy is an independent science organization supported entirely through community contributions. At venues throughout the region, we connect science and the community through free and or very low cost public talks, science seminars and workshops, and trips and tours that feature scientists and engineering professionals of both national and international renown. In addition to advancing the public understanding of science, it is our mission to inspire the next generation of scientists and science advocates, which we do by offering a full array of free and or low cost opportunities expressly for teens, such as our teen science cafes, STEM Teens Youth Leadership Council, Junior Academy of Science, and the Regional Academy of Science St. Louis Science Fair and Honors Division, this year all virtual. The Junior Academy is a pre-professional STEM membership organization for students from the full range of academic backgrounds in grades 6 through 12. It offers hands-on opportunities in science, engineering, and medicine. Teens can attend unique behind-the-scenes explorations of leading engineering, technology, and science labs of our region and participate in field opportunities and challenging and engaging science competitions, now all offered virtually online. And Junior Academy members make real-world connections meeting top STEM professionals. You can find more information on the Junior Academy and all of our community-wide science events and programs by visiting our website at academyofsciencestl.org, or you may visit us on Facebook, Instagram, or Twitter. You can also sign up to receive Academy e-news on our website, again at academyofsciencestl.org, or jot your email address down in the online program survey, which we will pop into the chat a couple of times this evening before you leave. And I do want to mention one upcoming event before I turn it back over to Denise to introduce our speaker this evening. If you are a teen or know of a teen who is interested in science, tomorrow night, Thursday, May 13th at 5:30 Central Standard Time, the Academy is hosting an interactive virtual teen science cafe, Putting COVID in Its Place, GIS mapping and locating our own experiences with the pandemic social changes with St. Louis University medical sociologist Dr. Christopher Prenner. So I encourage you to check that out. You can find more information and register online on our website at academyofsciencestl.org. And with all of that said, I am going to turn it back over to you, Denise. Thank you.
Thanks, Natalie. I kind of wish I was still a teen because that sounds like a really fascinating program. All right, so next, I'm so delighted to introduce tonight's presenter, Dr. Rebecca Lester, who's a professor of sociocultural anthropology at Washington University, and her program, Famished, Eating Disorders and Failed Care in America. Dr. Lester takes us inside a private eating disorders clinic to explore why treatments so often fail and what to do about it. So welcome, Dr. Lester. Thanks for being here tonight.
Thank you so much for having me. It's a real pleasure to be here, to be speaking with all of you. And I want to start this evening by reading just a little bit from the beginning of the book. But first, I'm going to share my screen. And let's get that going. All right. Hopefully you can see that. Okay. Can someone let me know?
Yeah.
Make sure that. Okay, perfect.
Yes, yeah, I can see it.
Beautiful. Okay, so I will start, like I said, with just a little bit from the beginning of the book before I get into the rest of the talk. This story begins with an ending. On a hot, sticky summer afternoon in 2009, I left the Cedar Grove Eating Disorder Clinic where I had been conducting research and drove to the local parish church. As I wound my way through the idyllic Midwestern American suburb, I passed the usual summer scenes. Children playing in sprinklers, shoppers at the local farmer's market, families out for a stroll. The sun was shining and it was peaceful and calm. The cheers from the nearby soccer field, a joyful soundtrack to an exquisite summer day. Yet all of this small town charm felt hollow and callous to me, sitting as it did in grisly counterpoint to where I was headed. A funeral for a young woman named Allison, who had been a patient at Cedar Grove the previous spring. Until 3 days prior, Allison had been a success story. When she left the clinic, she was healthy, invested in her recovery, thankful to be alive, and eager to get on with her life. Now, she was dead. She had a heart attack and died on the night of her 27th birthday. Allison was not my personal therapy client. I'm a psychotherapist as well as an anthropologist, but I'd come to know her fairly well during her time at Cedar Grove. In treatment, Allison worked hard, and over time, she made great strides toward health. By the time she was discharged 4 weeks later, Allison was medically and psychologically stable and looking forward to returning to her life. 4 months later, she was dead. At the funeral, Carmen and Sheila, two clients who had known Allison at the clinic and were still in treatment there, were sitting in the pew in front of me. They'd gotten special passes for the day to attend the funeral. I noticed that Carmen drew uneasy stares from the surrounding mourners. She had a feeding tube conspicuously inserted through her nose, the end of it taped awkwardly to her cheek. In the humid summer heat, the tape curled up at the corners, and her hands fluttered up repeatedly to press it back in place. Sheila, sitting next to Carmen, looked stoic and closed down, staring straight ahead into the distance. Both Carmen and Sheila looked visibly tense, their bodies held tight and rigid in the wooden pew. Carmen cried silently during the service, the tears snaking their way down her cheeks. Sheila sat still as a stone. Despite their obvious distress, I was glad to see both of them there, not only because they had been close to Allison, but also because I thought it might be a catalyst for them in their own recoveries, perhaps jolting them to awareness that this death could happen to them too. But later, back at Cedar Grove, Sheila told me that Allison's death had actually made her even less hopeful and motivated about recovery than before. It's just like, why fight it? She asked me. Once you have this thing for so long, it's going to kill you one way or another. So what's the point of trying to get better? Sheila's question was more than simply rhetorical. She wanted me to tell her why she should keep trying when she had cycled through treatment 3 different times, each time having to leave far before she was ready because her insurance ran out, and each time relapsing into a ferocious spiral of bulimia and self-harm. She wanted to know why she should keep trying when her parents had given up on her, her sister had stopped speaking to her, and now, including Allison, she had lost 3 friends in the last year to an eating disorder. Maybe I just can't do life, Sheila concluded, looking at her hands. So my book, Famished, is about how people care and make sense of caring in the face of what seem to be insurmountable odds. Clients who often don't want to get better, families who are in crisis yet resist change, an illness that kills more people than any other psychiatric condition, and a healthcare system that devalues the very sorts of clinical expertise that seem to help. It's about how clients and clinicians alike get caught up in these knots and must struggle to find a way forward, racing against the clock and the specter of disappearing benefits to access treatment that is complex, contradictory, and in far too many cases, counterproductive. Allison's death is an exemplar of the tragedies that can result from this situation. It is true that eating disorders are virulent, progressive conditions that do not easily relinquish their hold on sufferers. It is also true that many people with eating disorders are often ambivalent about getting well. But to figure Allison's relapse and death as the product of her personal relationship with her illness elides the ways in which care itself becomes complicit in the continuation and exacerbation of suffering. So these are the kinds of questions that motivated my research. I wanted to know why this is the case. How did we get here? That the situation is so dire that things like what happened to Allison happen again and again and again. And I want to talk for a little bit about how I, as a person, came to this research. And I come to it from 3 different perspectives at the same time, which certainly made things a little bit complicated, but I think were really necessary for the kinds of questions I was interested in. So as we've mentioned, I'm a cultural anthropologist. I'm a professor of anthropology at WashU. And after I was at WashU and I was a couple years into my position there, I decided to go back and pursue clinical training to get my master's in social work and pursue my license in clinical social work. And I'm also somebody who has a personal history with eating disorders and eating disorder treatment. So I came into this research from each of these different perspectives: anthropologist, clinician, and person who had had the experience herself. And this posed some challenges at times, and I'm happy to talk about that in the Q&A if people are interested in some of the ethics of navigating all of that. But I share this in the sense of giving some voice to the investment that I had in these questions and really wanting to understand from all these different perspectives what is going wrong with our treatment of these conditions. And so particularly as an anthropologist, what we really want to do is we want to get the story behind the story. So that's what I was after in doing this research. But what's the story that I wanted to get behind? Eating disorders, as we may or may not know, affect millions of Americans every year. Up to 30 million Americans is some of the more recent estimates. And what people don't often realize is that eating disorders affect more than twice as many people as Alzheimer's and 5 times as many people as schizophrenia. They affect male, female, young, old, Black, white, brown, rich, poor, across the community. We tend to think of them as being afflictions of young, white, wealthy girls. That's kind of the stereotype, but that is not the case. They affect everyone. There are reasons why certain populations become more visible in the eating disorder world than others, but they absolutely affect everyone. And they're dangerous. These are dangerous illnesses. They have the highest mortality rate of all mental illnesses, recently barely kind of edged out by the opioid epidemic. So that gives you a sense of like really what the level of the crisis is. And that's just recently that has changed. It can produce all sorts of serious medical complications: cardiac arrhythmias, cardiac arrest, brain damage, osteoporosis, infertility, obviously death. But more than this, the mental anguish of an eating disorder is really hard to capture in words. And that component of these illnesses lasts way longer than the medical consequences. And this is something that I'll talk about more in a few minutes. And as it says, not every suicide note looks like a suicide note. And I don't mean to suggest that eating disorders are necessarily a conscious decision to end one's life, but this is the natural consequence of the disease if it's not adequately treated. And to give a sense of the scope of the problem, every 62 minutes, at least one person dies as a direct result of an eating disorder. So during the time of this talk, at least one person will die because of an eating disorder. The good news about all of this is that eating disorders are treatable. They can be successfully and fully treated. I'm living proof of that. And there are many, many others who are. We do know things that work. We know things that help. And people can get better. It's not a hopeless situation by any stretch of the imagination. However, part of the problem is that so few people actually get the specialized care that they need. Only 1 in 10 people with eating disorders receive any kind of treatment at all. And only 35% of those receive specialized treatment for an eating disorder by somebody who's trained to work with eating disorders. And without this kind of proper treatment, we see people cycling in and out of care, in and out of hospitals, and the rate of recovery plummets with each time somebody relapses and comes back into treatment. And these are the estimated recovery rates from what we can tell from the data, that about 50% under current conditions, about 50% recover, 30% improve somewhat, and 20%, a whole fifth of the population, remain chronically ill or die. These are incredibly high numbers. And given that we know what works and what helps, this is really pretty astounding if you think about it. And part of the reason that we have these kinds of recovery statistics is that despite everything I've already told you about how prevalent they are, how deadly they are, eating disorders are among the least covered conditions by insurance. And they're allotted only a fraction of the research dollars as other conditions. If you look at them compared to, for example, Alzheimer's or schizophrenia or autism, they're just a tiny, tiny pennies on the dollar go into eating disorder research compared to these other conditions. And so we have millions of people who remain either completely untreated or vastly undertreated. And so the questions that I was really motivated by was, why? Why is this a situation? How can we possibly have an illness or set of illnesses that is so dangerous and deadly and so widespread in our society, and we have these pretty dismal recovery rates comparatively? How did we get to this point? What's going on? And what are the actual on-the-ground consequences of this situation for people, for clients, for families who are really trying to find their way through these horrible illnesses? And how can we work to improve it? So this was my ultimate goal with this research, was learning as much as I could about what the problem is, what it looks like on the ground, and getting some insights into what might be some leverage points for change. So I'm going to tell you a little bit about the research that I did. And I call the clinic Cedar Grove. It's a pseudonym. All the names that I use in this talk are pseudonyms. And it's a private eating disorder clinic in the American Midwest. And I worked there in a variety of capacities, spanning 7 years and a little bit beyond that. So I started off just purely as an anthropologist, going in to do an anthropological study. It was while I was there doing that research that I decided to pursue my Master of Social Work degree, in part because, inspired by the research, I felt like I really wanted to have additional skills to work with, do the kind of work I was doing, and to be able to do it ethically and responsibly. So once I was in my MSW program, I did my practicum hours at the same clinic where I was doing research, with, of course, everybody being fully aware of what was going on. And then once I finished my master's program, I worked at Cedar Grove for 2 years to get my licensure hours that I needed to get my independent licensure. So I've been there as an anthropologist, as a trainee, and as a therapist at different points in time. oh, well, here's my timeline, as you can see. So traditional ethnography, clinical trainee, therapist, and now I don't work directly with Cedar Grove, although I'm still in that orbit, and I do a lot of work with other organizations and clinics in the St. Louis area. So as far as how I went about doing this research, anthropology is, or cultural anthropology anyway, is based on this idea of long-term participant observation. So we go and we spend a lot of time with a group of people or a culture or an institution that we're trying to understand. And so for me, what that meant was trying to really understanding the everyday running of the clinic, what the timetables were, what different roles of people were, what kinds of things were happening in the clinic. I participated in the therapy groups, in the outings, in the meals. I was in the treatment team meetings, all the trainings for the clinicians, and I observed client and clinician interactions. So all of that is going on constantly. Everything is data when you're doing ethnography. And I should preface this by saying, of course, that the clients too were very aware of what I was doing, and I got informed consent from everybody to do the kinds of work that I was doing. So overall, it added up to about 5,000 hours of participant observation. I did my foundation and specialization practicums there, and then I did my 3,000 supervised clinical hours for licensure there. So a really long and involved time at the clinic. And so what was I looking for? I was looking at all sorts of things because I went in with a very open mind about, well, I don't know what the problem is per se. I know there's a problem, but I don't fully understand all the components of it. So I was looking at everything from how people used space to how they interacted with each other, the kinds of cliques that the clients would form, and sometimes the therapists as well, how people responded to change that came about. Whether or not people followed program rules and what it looked like when they did or didn't, who's making the decisions in the clinic, under what conditions, how are they implemented or not, and what kinds of other discourses are going on besides the kind of official clinic vision of what recovery should look like. What kind of other ways are people talking about what's happening? I also had access to and looked at a lot of different material sources. I had consents from the clients to look at their charts. So I could read through people's charts and look at all their history and look at clinical notes from other people and all of that. Certainly all the materials from the clinic itself, the treatment plans that clients and therapists developed, any training documents, insurance company plans, you get the idea. So anything and everything that I could get my hands on that I thought would help me understand this picture of what was happening, I did. I also did a bunch of interviews. I did 80 formal interviews with clients and therapists and some family members as well. And then hundreds of informal ones where you're just sitting around and a topic comes up and you ask some questions about it. So I had a lot of that data as well. And I was really interested in this question about why does treatment so often fail? I mean, here we are in one of the richest countries in the world with this supposedly stellar healthcare system, and we know what works for people. And so why isn't it working? And what can we do to improve the situation? And these questions, to answer these questions, I found myself kind of engaging with much deeper questions as well about how is it that we even understand what eating disorders are? Like, what is our concept of what these illnesses are, and how do we think about who's at risk? And I don't have time to go into it here too much, but it has a lot to do with the legacy of concepts of hysteria way back from, Victorian times that you can trace it through into contemporary psychiatry, even though we certainly don't use that word anymore. But there's enormous bias in the psychiatric community against eating disorders that I'll talk about more in a minute. It led me to think about these questions of what is good treatment? How are we defining what good treatment is? And how are we defining what recovery means? Because these are terms that we throw around in the research a lot and in the data a lot, but what do we mean by them? And how is that shaping the kinds of answers we're finding? And how has all of this changed under the conditions of managed care? This is something I became very interested in. I first started researching eating disorders back in 1992 when I was a graduate student. And that was right as managed care was kind of coming on the scene. And so as I returned to this topic 10 years later, the transformation was complete as far as managed care. And so I was really interested in how all of this was being shaped by this really foundational shift in the way that we understand healthcare and healthcare economics and how decisions are made. So the issue of managed care is really important here. I won't go into all the details about the history of managed care and all of that kind of stuff, but I will say that what I witnessed in the clinic was that managed care is running the show. This is true in a lot of medicine. It's not unique to eating disorders, but it does have particular inflections when it comes to eating disorders. Eating disorders, if you're thinking as a managed care company, you're a for-profit company, you've got to keep your shareholders happy and you're looking to spend less money than you're taking in premiums, right? So you want to minimize what you're paying out, you want to maximize what you're bringing in. And from that perspective, eating disorders are fairly expensive to treat because they take a long time. They require an interdisciplinary team. So you've got, a psychiatrist, a medical doctor, a dietitian, a therapist. You've got, a big team going on. And treatment, as we've seen, doesn't always work. In fact, it often fails. And so from a company perspective, the question is, why should we spend money on this stuff? Why are we throwing money at a condition where people don't want to get better and treatment isn't working and it's expensive, right? So that's the insurance company rationale. And part of the problem comes from the way that they are understanding what the client's moral orientation to health is. So the perfect patient in an insurance company view would be someone who strives for health, to maximize health, to minimize harm, follows the rules, follows the directions of the doctor's orders, and gets well quickly and moves on. And that is about the opposite of what you find in eating disorders. And so there's this tension that's built into the system where if somebody shows up for treatment with an eating disorder, automatically the insurance company is suspicious of them and sees them as a bad investment. And they are wary of any demands or requests for care that this person is after. So this already sets it up as a problem. And then we'll see what happens when treatment gets going. So if we think about this issue of, why does treatment fail? Why do clients so often fail to get well? Well, the standard explanation by the insurance company, but also in the history of psychiatry, where we have another set of biases, is that these are difficult patients. That's what they're generally called. These are difficult patients and they're resistant to treatment and they don't want to get better. So you see, all this negative language about difficult and resistant and don't want to get better. Well, in my experience, in my research, that is not really what's going on. There may be some elements of that resonate, but that's not what is causing the problem. What we see are the consequences of managed care on eating disorder treatment. Only 3% of health plans cover anorexia according to the American Psychiatric Association guidelines for what care is needed and when care should be delivered. So for example, the APA says, once here are the criteria we have for when somebody meets medical necessity for anorexia or bulimia or binge eating disorder or something else. Well, the insurance companies say thank you very much, but they don't have to follow those as their criteria for when they're going to authorize care. That's a whole separate thing. So they can say, we recognize the APA has this criteria, but our criteria are different. And so we require somebody to be even sicker than that before we're going to authorize inpatient treatment, for example. Similarly, the length of treatment is often much lower than the recommended standards of care. So similarly, APA or other credentialing bodies may say, we recommend you reach, 90% of ideal body weight, and you have these kind of behavioral markers of recovery before somebody's discharged. And again, the insurance companies can say, that's very interesting, thank you, but no, we're gonna do it this way. And on top of all of that, they often provide circumscribed benefits specifically for eating disorders, or many of them actually exclude eating disorders from treatment altogether. It's just not something that they cover. So the consequences of this are very severe, and 1 in 5 eating disorder specialists believe that insurance companies are indirectly responsible for the death of at least one of their patients. And as you see here, almost 97% believe their patients with anorexia in particular are put in life-threatening situations because of health insurance companies' refusal to cover treatment. I saw this again and again and again at Cedar Grove. Now, we may think we have this Affordable Care Act, we have, healthcare parity now, we're supposed to have coverage for mental health on parity with physical health. Well, it doesn't really play out like that on the ground. And so this is from data from 2015 that shows what kinds of conditions are excluded from coverage. 0% for drug and alcohol. For autism, about 6% of plans will exclude autism from coverage. 22% exclude eating disorders from coverage. So it doesn't matter if you have great insurance, if you have an eating disorder on one of these plans, you cannot get insurance coverage for treatment. So the message that this sends to clients is that they need to be sicker if they want to get care. And this really is problematic when we think about the underlying experiences of having an eating disorder as being one of not being deserving of care, of not being deserving of food or comfort or health in any way. And for somebody to finally get to a place where they are willing to reach out for help because they are so ill, and to be told, sorry, you're not sick enough to deserve treatment from your insurance company, it just redoubles the messages that we are trying to help people heal from. So this idea that you're never sick enough, that you are not sick enough to deserve care. And it replicates and reinforces these dynamics that we see in eating disorders, this idea of rationing, of restricting and withholding, that we are supposed to be combating and helping somebody get to recovery. We're supposed to be helping people let go of these things. And yet the entire structure of treatment is conditioned on exactly those kinds of dynamics. So when patients, quote unquote, fail to overcome this double bind, they are viewed as failures. The structure is not viewed as a failure. The client is viewed as being difficult, being resistant, not wanting to get better, which just further justifies the withholding of care. So we have this kind of self-perpetuating system. And I want to give you just briefly 3 cases to illustrate how this plays out. One moment. Okay. So I want to tell you a little bit about Hope. Hope at the time of the research was 13 years old. She was the youngest client that was ever at Cedar Grove, at least when I was there. And she did have insurance, but it only provided for a very short period of time. And she was very ill when she came in. She had been in inpatient care in a hospital before she came to residential care at the clinic. And her insurance was running out. She had made some progress. She had gained some weight, but she was about to lose care. And she was nowhere near being well. And so the treatment team knew that if she was discharged from care, she was going to go home, she was going to relapse, and she might die, because that was it for her insurance for that year. Her family did not have resources to private pay. It's extremely expensive to pay out of pocket for eating disorders treatment. So they were scrambling and trying to figure out what they could possibly do to help this person. So they found at a local university that there was a research study going on of a particular kind of treatment for anorexia. And that if they could get her enrolled in this research study, she had a chance of being randomized into the group that received this experimental therapy. She could be randomized into the control group or not, but she had a 50-50 chance of getting actually randomized into the care group. The trick was, in order for her to be enrolled in the study, she had to meet the criteria of the study. she had gained enough weight where she was about 86, 87% of ideal body weight, so still very low. The study required an 83% body weight to enroll somebody in the study. So the clinicians found themselves in a real bind. And what they did to help her get care was they put her on a diet inside an eating disorder treatment center to get her weight low enough that she could be enrolled in this trial and potentially be randomized into the care group. So this is completely mind-blowing. Of course, and the clinicians were very aware of the problems inherent in this situation, but there were really no other resources. This was the only thing they could figure to do. It was a choice between no care at all and possible limited care. And they had to take this chance. And so this is an example of how, because of the structures of insurance and also the structures of the kind of research institutions and research programs, caring for somebody can look like harming them, because sometimes we have to subject them to these kinds of things in order to possibly have access to care. I don't know which group she was randomized into. By the way, she did lose the weight and she was enrolled in the study, but I don't know what happened to her after that. Kaylee is a somewhat different story. When Kaylee came to treatment at the clinic, she was 28 years old. She had been diagnosed with anorexia for about 10 years. She'd been active with her eating disorder, and she was at the point where the only thing she would eat was, she would have 6 to 8 zucchini that she would cook on the stove between 2 a.m. and 8 a.m. every night. And that's what she ate. And this schedule ruled her life. So of course, if she's up from 2 a.m. to 8 a.m. eating her zucchini and she's not getting any other sustenance, she was not really functional during the day, and she had to quit her job and she dropped out of school. She had lost her period. She had severe osteoporosis, and she was completely governed by her eating disorder. So in treatment, when she came to the clinic, it was a big task just to get her regulated on a kind of normal daily cycle where you get up in the morning and you go to bed at night and you eat during the day and you have more than zucchini. So she's there, this is happening, but sometimes what happens with an eating disorder, if somebody is really in a starvation state, is they can get something called refeeding syndrome. And she didn't entirely get that, but bodies struggle to process food when they're not used to having food. And so what happened in Kaylee's case is that she developed really severe edema, swelling, and it's water retention in your body that can happen. But in her case, it was so severe that her legs were so swollen, her ankles and her knees were so swollen, she could not bend her legs. I mean, it was incredibly painful. And she gained a ton of weight because her body was withholding all of this water, right? So it was all water weight, but the insurance company was super happy because they're like, oh, great, she's gaining, 8 pounds this week. And nobody gains 8 pounds a week. That doesn't happen unless it's something like water weight. But the insurance company really wasn't so concerned about that. They measure things according to numbers and what is your weight doing. She was continuing to eat to become nourished. She did, after a couple of weeks, her period returned. And she was devastated because for her, that indicated that she was reaching a healthier weight, but she was still extremely ill and very, in her mind, very invested in her eating disorder and nowhere near ready to discharge. Well, the insurance company, being interested in the kind of biomarker things that they're interested in, said, oh, well, she's gained all this weight and she started her period, so she's healthy. So now we're going to discharge her. And the clinicians were like, absolutely not. She's nowhere near ready to go. Kaylee herself was saying, I'm nowhere near ready to go. The insurance company said, sorry, we're done. You're discharged. And within 2 weeks, Kaylee, not surprisingly, was in full relapse, back to her zucchini, back to everything. She called the clinic for help. She wanted help. And the clinic tried to get authorization for her to come back into care, and the insurance company denied her care because they said since she relapsed after leaving treatment, she had failed care and they were not going to pay for someone who had failed care. The last case I want to share with you has to do with Anita. Anita had been a client, and she was somebody that I worked with individually. She had been in Cedar Grove for a couple months at one point, and then she discharged for a while. And I came in one day to the clinic, and I see her sitting there on the couch, and I didn't know she was coming back. She's on the couch, and she was bundled up in a big sweater, and she just looked at me and she started sobbing. And she said, "Rebecca, I relapsed really badly." And she moved her sweater aside, and I could see her body, and I could see how sick she was. And it was really heart-wrenching to see. It was very difficult. And so I was talking about this later on with a woman I'll call Claire, who was one of the clinic nurses. And I was telling her, it was really difficult to see Anita back here. And I expressed my concern for her well-being. And Claire let out a snort, and she rolled her eyes and she said, "Oh, please, don't you see what she was doing? She was totally manipulating you, trying to get you to feel sorry for her because she's so sick. You cannot validate that. It's exactly what she wants." So I found that really perplexing. And the more I thought about it, the thornier this issue appeared. So there was no question at all that Anita was literally deathly ill. That was very clear. But Claire's perspective, which is consistent with other clinicians, this was not unique to Claire and consistent with other places, it's not unique to Cedar Grove, was that Anita was trying to solicit this kind of acknowledgement of her suffering in a kind of manipulative way, that she wanted attention for being sick. And so from Claire's perspective, what my job was as a newbie therapist at that time was to not gratify that need of hers to get attention for being sick, because it's going to reinforce that. That was the idea. But what that expressed to me that I found really perplexing is like, okay, so we have somebody who's really ill, and so we're supposed to specifically not respond to the fact that they're really ill. We're supposed to withhold care as a way of caring for them. And this just illustrates how these double binds get set up for everybody in this scenario about how to think about this process of getting somebody well from an eating disorder. And it's the kinds of ways that the ideas of the insurance companies and this withholding and scarcity of resources filters into the therapeutic relationships as well. That there's a scarcity of attention, there's a scarcity of capacity that the clinicians have because they're overloaded. And this idea that we have to be so careful with whatever we dole out of care, even if it's just empathizing with somebody, that's a scarce resource as well. And reinforces for the clients that you don't deserve somebody to care about the fact that you're on death's door. So what can we learn from these kinds of cases? We learn that clinicians, eating disorder clinicians, are caught between contradictory ethical systems. They have the eating disorder, the insurance companies breathing down their necks about get people well, get them out, focus on weight, focus on lab results, focus on things like that. And then they have their therapeutic training that says there's so much more going on here than just what somebody weighs on a scale. That there's much deeper issues that need to be attended to, and we need to show empathy, and we need to connect with our clients, and we need to help them through this process. And they are caught between these two different systems that are not really compatible with each other. Clients, for their side, have to learn how to be sick in a certain kind of way that's not going to be perceived as manipulative, but that is going to get them the care that they need. They don't want to be seen as difficult, but they want to have a say in what is happening to them. One of the things I talk about in the book is that there's really no way to win as a client when you're in an eating disorder treatment situation. There were cases where even when clients were complying with what the treatment recommendations were or complying with the program, that was sometimes interpreted as being manipulative because they were trying too hard to please people so that they could get what they want. So it didn't, there's kind of no way out when you're in this situation as a client. It's very difficult to navigate all of that. And care gets completely reconceptualized and reconfigured from something that's, something we provide to people, attention, care, comfort, excuse me, to something that needs to be restricted, to deprive people of, that we need to withhold and guard very carefully. Like they want it, we have it, and we can't let them take too much of it. And all of this combines to, of course, reinforce these core elements of an eating disorder: that you're not sick enough, you don't deserve health and comfort, you don't deserve care, don't deserve attention, and your body is the referendum on your moral self, whether or not you're deserving of care or attention or resources. And so what I saw in the clinic is that the clinicians that I worked with really had very good intentions. They got burned out and stressed out and, stuff like that, like everybody, but they were very serious about their care for these clients, but they found themselves in an impossible situation where they're operating within a system that's recreating and legitimating these patterns, of restriction, withholding, and moral evaluation, and this hyper focus on the body that they're also trying to counsel clients to let go of, right? So we're telling clients, you need to not think of your body as indicating, your worth as a person, but yet that's exactly what the insurance companies are using to determine whether or not they have access to care. And so when we steep clients in this kind of system, and then we send them off before they're well, while they're still really ill, it's not a wonder that they relapse. This is not a surprise that people are not getting better, or that they relapse and they come back for care, or they try to, but then they're denied because they're blamed for not wanting to get well. And this is something I call ethical offloading. It's a kind of displacing onto the client the dysfunction of the system, right? And so we blame clients for being difficult or resistant, not wanting to get well, as opposed to really reevaluating the structures of care that are producing these conditions. And so one of the things I explore in the book is this question of, why does this persist? How did this whole mess come to be, and why does it persist? And part of it, I think, is that eating disorders become kind of like a problem child in a dysfunctional family system, where it carries the symptom of a broader dysfunction, that it is a place where these kinds of conflicts can be kind of intensified and housed, and managed care doesn't, the logics of managed care that are certainly bigger than managed care, that have to do with our capitalism and other kinds of things as well, doesn't have to, be reflected upon, that we can blame the clients for being the ones who don't want to get well. So what is the story behind the story? There's not enough of the right kind of care for the right amount of time. That's clear. But it's more than this as well. We don't need more care as usual. That's not the answer. Because eating disorder clients don't fail treatment. Treatment fails clients. And this is something that I think is really important to understand. People come into treatment because they are ill and they need help. And for us to then expect them to somehow navigate and resolve all of these double binds that we put them in is just absurd. And so we then say they failed, as opposed to the treatment has failed them. So just a few closing points about where we might go from here. So what do we do about all of this? And it's a huge problem, and I don't pretend to have some magic solution to it, but there are some things that we can do. We can change the language, the way that we talk about these illnesses. This is a public health crisis, and we don't usually hear of eating disorders discussed in that way. But if you look at the numbers, I mean, it is a huge public health crisis, and the kinds of burden of disease that eating disorders carry, physiological as well as mental and emotional, is enormous. It's a crisis, and it's an issue of equity when we're thinking about who is getting accurately diagnosed, who is receiving care, who is not. These are issues of equity. And one way that people have tried recently to try to get more equity for treatment of eating disorders is to go the route of focusing on the biological or perhaps genetic underpinnings of eating disorders, of which there are some, certainly. I would like to caution against us going too far down that road of focusing on biologizing the illness as a way of validating it. What I think that does is it continues that focus on the body, on numbers, on that aspect of things, as opposed to what an eating disorder, in my mind, really is, which is a much bigger and deeper existential crisis that people need help navigating. And the body weight stuff is real, and it's the end point of what the crisis really is. That's much deeper. So if we just focus on the kind of biological components of it, that's great. We might get more research funding that way, but that's going to take us further down a road that I think gets us away from what really needs to be attended to. We definitely need better education. So for physicians, I can't tell you how many physicians have said really unhelpful and even very harmful things to patients with eating disorders, not intentionally by any stretch, but they just don't know. They don't know enough about what eating disorders are to know how to navigate things with sensitivity, or how not to present information. I know people who've been through psychiatry training programs and residencies, and they get maybe a day on eating disorders, maybe two, if they're lucky. Some don't get any. So they just, even specialists don't know. So they have to pursue additional training. If somebody's interested in working with eating disorders, there's a lot of different, specialization training programs that you can do, but that's on top of the regular medical training or psychiatric training that people get. It takes it's something people have to seek out, as opposed to something that's built in to the regular training that we give to physicians. We need to educate the public, certainly. Part of the difficulty with that is there's so much shame around these illnesses that people who have had an eating disorder often are really reluctant to talk about it, or families of people with eating disorders, because we have so much blame on families for causing them, don't want to talk about it. So it's shrouded in this secrecy. And so we need more education for the general public. Absolutely, policymakers need to be educated as well. And there are some initiatives that are seeking to do that. In terms of research, we need to really think about what are the outcomes that we're measuring. If all of our research is measuring outcomes based on weight gain, then that skews the way we think about what an eating disorder is and when we know somebody's recovered. We need more reliable community-based data. We need to show that these are not just the purview of one small sliver of the population, that it's widespread and that many people are struggling with it. And we need to better understand the long-term burdens of these eating disorders as well. For treatment, we certainly need to require coverage for eating disorders. It's baffling to me, given how serious these conditions are and how widespread they are, that we have to fight state by state to get them covered. There are initiatives in various states around the country. There are some national initiatives as well that are trying to get these covered, but it's still an uphill battle. We want to get the insurance companies, to follow the standards of care that are recommended by the specialists. We want them to cover all treatment modalities, including when I say continuity of care. So we've got, oftentimes somebody may have coverage to get inpatient treatment in a hospital and outpatient once a week therapy and nothing in between. Or they may have coverage for residential, like 24-hour care, and then not, just 10 visits for an outpatient therapist or something like that. So we need a full continuum of care that's actually covered for people. We have, like I said, and there are a number of initiatives, including a bill that was passed in Missouri that does require insurance companies to cover eating disorders that operate in Missouri. There aren't really any material consequences for companies that don't. So although it is the law, that doesn't necessarily mean that people are following it. They more are following it than they used to. So that's good. But there's not real material consequences if they don't. The Missouri Eating Disorder Association is a local organization that does a lot of work in trying to educate the public and to educate school, like teachers and coaches and nurses at schools and things like that, who may come into contact with them, what to look for, how to make referrals, what to do. And there's something called the Missouri Eating Disorder Council that works statewide that's trying to expand treatment options to rural areas and develop centers of excellence outside of St. Louis and Kansas City, where they're pretty much located now. And then I mentioned there are these national efforts, the National Eating Disorder Association and the efforts for the Freed Act are all, looking to try to get parity for eating disorder coverage around the country. So what is the bigger payoff of this kind of research? I did this research for a really long time. It takes, it doesn't take a full 7 years to do research usually, but because I was involved in all these different capacities, that's how long I was there. So it's a huge investment of time and energy. And you got to think about why not just drop in and do some questionnaires and get some outcome data and draw some conclusions that way. Well, I think what is really valuable about an ethnographic approach to these kinds of questions is that it helps us get insight not only into the conditions themselves, but to understand better the conditions that are producing them, that are enabling them, and perhaps even require these conditions in order for the system to thrive. And we would not understand that dimension of it were it not for this kind of long-term, in-depth kind of participant observation research. So that is some of the payoff of ethnographic and anthropological research for these kinds of questions. So I will wrap up there. This is a picture of the cover of the book. And I am very happy to answer questions or have any discussions from here. So let me stop sharing my screen.
Yeah, thank you so much, Dr. Lesser. That was very informative, and I'm glad that we're able to, get this information out there for people to hopefully, just become familiar with it and the issues that it brings forth. So thank you so much for that. And for everybody that's attending, I did open the chat box, so that's now enabled. So if you have any questions related to tonight's program, please feel free to include those in the chat. And if this is your first Zoom program, in order to do that, when you move your mouse or cursor, you'll notice your Zoom control panel appear either at the top or the bottom of your screen. And there's one button that looks like a dialog box labeled chat. Just click that, and that should pop the chat box up on your right, where you can then type and press enter to include your question. All right. Does overeating mean a different treatment than anorexia? I have a friend who has had no luck in combating the overeating to great obesity.
That's a great question. And it does require different treatment in certain ways and in other ways not. It depends somewhat on what the issues are. If somebody's struggling with kind of compulsive overeating, where they really want to stop but find that they can't, that is perhaps meets the criteria for binge eating disorder, which is an eating disorder, can be treated residentially or in an outpatient way. It does have its own kind of treatment profile that is a little bit different than anorexia, but a lot of the issues are the same. They may manifest differently, but a lot of the underlying issues about feeling so much shame and unworthiness and having a real question about who am I outside of this condition can be shared among them. But there's absolutely treatment out there. If you find somebody who specializes not in dieting, but in eating disorder treatment, it is available.
And do you take clients now in a private practice setting?
I do, yes. I have a private practice and I do see clients. So certainly you can email me. I can put my email in the chat. If anybody has, wants any information about that, I'd be happy to share. Yeah,
thank you. And let's see, you mentioned biological pinning to eating disorders in your research. What role did micronutrients play a role, B12 deficiency, zinc, etc., along with the emotional problems?
That is an excellent question that I am not qualified to answer. except like I can't answer in that degree of specificity, but I can say that when somebody is malnourished, whether they're underweight or not, you can be malnourished and not be underweight because you're missing these kinds of essential nutrients. Like for Kaylee, the one I talked about who was eating zucchini, her protein levels were off, all of her nutrients were off, right? And when somebody biologically is dealing with something like that, it of course affects mental and emotional state as well. So those are very intertwined, but I'm afraid I can't comment on those particular micronutrients. Yeah.
And we have a comment. Let's see.
Okay.
I think people should target teens for info about eating disorders since their mental health is one of the worst, and they will likely take the info onto later in life. Also, let them know that eating more is good, how gaining weight as children and teen is healthy. Thank you for the informative keynote. P.S. I recommend using Safari because it's more secure.
It's good to know. Thank you.
Let's see.
So I will say the Missouri Eating Disorder Association has a fantastic program that goes into schools throughout the region to educate teens about with responsible education about eating disorders and healthy eating and how to recognize that somebody might be in trouble and what to do.
How do I find doctors that address the obesity associated with side effects of psych drugs? This too is never addressed by doctors, and she gets blamed just like the anorexics do when it is a known side effect for taking prescribed meds.
That is a real problem. Yeah, I am not sure. That wouldn't necessarily be an eating disorder, although it might be. I don't know your friend, but that is a real problem. And that's horrible to hear that somebody is blamed for a side effect of the medication that they're taking in order to try to be well. She or he could certainly contact one of the clinics in the area. There's at least two that I know of. There's McCallum Place, and what used to be Castlewood is now called something else that I'm completely forgetting right now. Alsana, there it is.
Yeah.
And ask them. They probably have some referrals that they can give for somebody who can help with that.
Do eating disorders get worse with age?
Well, they can if they go untreated, certainly. I'm not sure if that's exactly what you're asking, or if you're asking if somebody gets an eating disorder later in life, is it worse? I'm not exactly sure, but but yes, if somebody has an eating disorder as a teenager and it goes untreated, it can get worse and stay at it can lead to death, or it can lead to a state of just miserable existence, like Kaylee, right? Or Anita would be another example. As far as there are cases where people, more and more women over 40 are showing up at clinics with eating disorders. And there's a whole bunch, we can hypothesize about why that might be, but you also see people in later years getting them or struggling with them now. Yeah.
How can you assess if you have a good healthcare team assembled for an ED?
I think it's really important to find out what their training is, certainly. If they have experience in working with eating disorders, it's really important that somebody have some sort of additional training. If they live somewhere where that training is not available, although it is, of course, you can get stuff online now, but that they have done enough study or enough interacting with that community that they understand what's going on. I would say overall, for any treatment team, feeling like you're being heard, even if you don't always agree with the treatment team, but feeling that they are listening to you at least and taking you seriously is super important. If you're feeling written off completely, then that's not a great sign. But yeah, that would be my main thought on that.
Has anyone studied the root cause of eating disorders as nutrition? I believe is a base. How can we advocate the cause?
I am sure that people have looked at that in more detail than I have. I've been looking at this other kind of set of issues, but there have been a lot of work done on kind of what's happened with the American diet in particular over the past 100 years or so, and how that can coincide with what we see in the rise of different kinds of eating disorders. So there is some work out there on it, yes.
And would a 68-year-old obesity condition of binge eating be tough to treat?
Um, Not, well, tough, yeah, but not impossible. Eating disorders in general are tough to treat, but they are treatable. And I would absolutely encourage somebody, even if they've been struggling with it for a very long time, to seek out care. It is absolutely treatable.
Um, All right. It looks like that's the last of our questions. And Dr. Lester did provide her email there. So if you do have some follow-up questions or concerns, thank you for doing that. I appreciate that because there were some comments in the chat. So from people that will probably be reaching out.
Great.
And again, thank you so much for this information. It's really valuable. And I'm very happy that, we can get it out there. And again, it's going to be posted to our YouTube channel up until, let's see, so it's May, up until July 1st. So if you have some friends or family members that are interested, please refer them to our YouTube channel. It will be posted there in about 3 to 4 business days. And again, thank you so much, Dr. Lester. I enjoyed your informative talk, and I do feel like we got some good information to help, try to advocate for better treatment. So thank you so much.
Thank
And
you.
thank you all for attending.
Yeah, thank you to everyone.
Have a great evening.